Welcome to the Deep Dive, your shortcut to being well-informed. Today we're diving into something that sounds maybe a bit technical, but is absolutely vital for your health.
Awesome.
Hypokalemia. That's basically a fancy term for low potassium in the body.
That's right.
Our mission today is to really unpack why potassium is so critical, what actually happens when your levels drop too low, and importantly, how we can understand and manage this often overlooked piece of our health puzzle. We've gathered insights from some really thorough sources to give you the clearest picture possible.
Exactly. And, while potassium might seem simple, like just another mineral on the list, its balance is incredibly precise. It's crucial for, well, almost everything your body does physiologically. And a deficit, it can have really profound consequences.
Profound how?
We're talking serious risks if it gets severe, things like cardiac arrest or respiratory arrest. It really is one of those silent but powerful regulators inside us.
Okay, so definitely not something to ignore. And by the end of this deep dive, our goal is for you to have that complete picture. Moving beyond just general awareness to some genuinely surprising details and practical takeaways. Get ready for maybe a few aha moments you didn't see coming. Let's jump right in. First things first. What is a potassium deficit, medically speaking? How is hypokalemia actually defined?
Okay, so the official definition, based on our sources, kicks in when your serum potassium level, that's what we measure in a blood test, drops below 3.5 milliequivalents per liter, or 3.5 millimole.
3.5. Got it.
But there's a bit of nuance here. Usually, yeah, a low level in the blood means your total body potassium is low. However, sometimes, and this is important, your blood level can be low even if your overall body stores are actually normal.
How does that happen?
Think about conditions like alkalosis, where your blood pH is too high. This can cause potassium to temporarily shift out of the bloodstream and into your cells. So the total amount in your body might be okay, but it's hiding inside the cells, not circulating in the blood where we measure it. It's like it's gone off the main highway onto the side streets.
Ah, okay. So the measurement doesn't always tell the whole story immediately. That's helpful context. All right, let's unpack this then. If potassium's so vital, what are the primary ways someone actually develops hypokalemia? How do levels get that low?
Well, there are quite a few pathways, and often they're, linked. A really common one is medication-induced.
Like what kind of meds?
Certain diuretics are big culprits, specifically thiazides and loop diuretics. They help get rid of excess fluid, which is often needed, but they can also cause you to lose potassium in the process. Other drugs, too, like corticosteroids, certain antibiotics like sodium penicillin, and antifungals like amphotericin B can also play a role.
Okay, medications are one big area. What else?
Gastrointestinal losses are another major factor. Think about frequent vomiting or significant diarrhea. You lose a lot of fluid, and that fluid contains potassium. Our sources mention that intestinal fluids can have as much as 30 millieql of potassium.
Wow, that's a lot.
It really is. So things like prolonged intestinal sectioning after surgery, having a recent ileostomy, or even rare conditions like a villus adenoma, which is a type of tumor that secretes potassium-rich mucus, can lead to significant losses.
Makes sense. What about internal body chemistry? You mentioned alkalosis shifting potassium earlier.
Exactly. Acid-base imbalances are key. When your body's pH is too high, so metabolic or respiratory alkalosis, the body tries to compensate. Hydrogen ions move out of the cells into the blood to lower the pH. But to maintain electrical balance, potassium ions then move into the cells. So again, potassium leaves the bloodstream, lowering the serum level, even if the total body amount hasn't changed yet.
It's like the body's robbing Peter to pay Paul, trying to fix the pH but potentially causing a potassium issue.
That's a good way to put it. It's a compensatory mechanism with a potential downside. And speaking of the body's internal regulation, hormones are also major players.
Like which ones?
Aldosterone is a big one. It's made by your adrenal glands. Its main job is to tell your kidneys to hang on to sodium and water, but the trade-off is it tells them to excrete potassium. So if you have too much aldosterone, maybe from an adrenal tumor, which is primary hyperaldosteronism, or secondary to things like cirrhosis, heart failure, or malignant hypertension, your kidneys are constantly being told to dump potassium.
Leading to potentially severe depletion over time.
Absolutely. Then there's insulin. Insulin actually helps move potassium from the bloodstream into cells. So situations like persistent hypersecretion of insulin, or even when patients receive high carbohydrate 5E nutrition, which stimulates insulin release, can cause potassium levels in the blood to drop.
Interesting. And what about diabetes specifically, like in DKA?
Diabetic ketoacidosis, or DKA, is a really important example. Initially, because of the acidosis and lack of insulin, potassium actually shifts out of cells, so blood levels might look normal or even high. But, and this is critical, once you start treatment with insulin, the insulin pushes that potassium right back into the cells. This can cause a rapid, sometimes dangerous drop in blood potassium levels, hypokalemia.
That's a dramatic swing. A real watch out during treatment.
Definitely. And we also have to consider just plain inadequate intake.
Just not eating enough potassium-rich foods.
Right. If someone is unable to eat normally for a long time, maybe they're severely debilitated, perhaps an older adult with poor appetite, or someone struggling with alcoholism or anorexia nervosa, their dietary intake might just not be enough to keep up.
And for bulimia.
Yes. With bulimia, it's often a combination: poor intake coupled with self-induced vomiting and sometimes overuse of laxatives, diuretics, or enemas, all of which can deplete potassium.
Okay, that covers a lot of ground. Is there anything else major?
Yes, and this one's, well, it's often missed, but incredibly important. It's the magnesium connection.
Magnesium, how does that fit in?
It's fascinating, really. If your magnesium levels are low, it actually causes your kidneys to waste potassium. They just can't hold on to it properly. And here's the real kicker. You have to correct the low magnesium first. If you don't fix the magnesium deficit, trying to replace potassium is like pouring water into a leaky bucket.
Wow.
The kidneys will just keep losing the potassium you're trying to give. So assessing and correcting magnesium is absolutely crucial before, or at least alongside, potassium replacement.
That is a huge clinical pearl right there. Okay, so we've got a good handle on how this happens. Now, let's shift to what it actually looks like. What are the signs and symptoms? How does low potassium manifest in the body?
Well, the clinical signs usually start becoming noticeable when the serum level drops below about 3 MEQL. And just to reiterate, the seriousness, severe hypokalemia carries that risk of cardiac or respiratory arrest, so recognizing it early is vital.
So what should people or clinicians be looking out for?
Common symptoms include significant fatigue, just feeling wiped out, loss of appetite, or anorexia. Muscle weakness is a big one. It can range from mild fatigue to, severe weakness affecting even the respiratory muscles. Decreased bowel motility is another thing, slow down in the gut, leading to constipation or even ileus in severe cases. Paresthesias, too, that pins and needles feeling or numbness.
And the heart. You mentioned cardiac arrest risk.
Absolutely. Arrhythmias are a major concern. Potassium plays such a key role in the heart's electrical activity, so low levels can destabilize the rhythm.
What about longer-term effects if it's not corrected?
If hypokalemia persists for a while, it can actually damage the kidney's ability to concentrate urine. This leads to producing large volumes of dilute urine, that's polyuria, which often means frequent urination, including waking up at night to go, that's nocturia, and excessive thirst. It can also suppress the body's release of insulin, potentially leading to glucose intolerance or worsening existing diabetes control.
And you mentioned something about a specific medication interaction earlier.
Yes, and this is a critical safety point. Hypokalemia significantly increases the body's sensitivity to digitalis, or digoxin, a HERP medication. This means that patients on digitalis can develop signs of toxicity like arrhythmias, nausea, visual disturbances, even if their digitalis blood level seems to be within the normal range.
So the low potassium makes the drug effectively more potent or more dangerous.
Exactly. It's a really important interaction to be aware of for patient safety. You need less digitalis to cause problems when potassium is low.
Got it. So we know the signs, the risks. How do clinicians actually confirm it? What are the diagnostic steps?
Well, the starting point is that serum potassium level we talked about, confirming it's less than 3.5 milliQL. But beyond the number, the ECG, the electrocardiogram, provides really valuable clues.
What changes do you see on the ECG with low potassium?
You often see flat T waves, or sometimes they can even become inverted, which can mimic signs of heart ischemia. Depressed ST segments are also common, but the most characteristic finding, almost a hallmark sign, is the appearance of an elevated U wave. It's this extra little wave after the T wave that becomes prominent.
Is that different from hypotassium?
Very different. Hypotassium hyperkalemia has its own distinct ECG changes like peak T waves and widened QRS complexes, so the ECG can really help differentiate.
Okay, ECG is key. How do you figure out the cause if it's not obvious?
Often, a good, thorough patient history points you right to the cause, asking about medications, vomiting, diarrhea, diet. But if the cause isn't clear, a 24-hour urine collection to measure potassium excretion can be very helpful. Basically, if someone is hypokalemic but their kidneys are still putting out a lot of potassium, say more than 20 milliu per day, it strongly suggests the kidneys are the source of the loss, maybe due to diuretics or a hormonal issue. If the urine potassium is low, the loss is likely happening elsewhere, like the GI tract.
That makes sense, tracking down where it's leaking from. Okay, we've covered what it is, why it happens, what it looks like, how it's diagnosed. Now the crucial part, management and prevention. What do we do about it?
Right. The approach really depends on the severity and the cause, but generally we start with the basics. Dietary management is often the first step, especially for prevention or mild cases.
Boosting potassium through food.
Exactly. For people at risk, ensuring their diet contains enough potassium is key. The average adult typically needs around 50 to 100 millieq per day.
And what are the go-to foods for that?
Lots of fruits and vegetables are great sources. Think bananas, melons, citrus fruits. Fresh or frozen vegetables are generally better than canned, as processing can lower potassium content. Legumes, whole grains, milk, and lean meats are also good contributors.
So a balanced, whole foods-focused diet generally helps.
Pretty much. But sometimes diet alone isn't enough, or the deficit is more significant. That's when oral potassium supplements come in. These are usually prescribed as potassium chloride, KCl. It's also worth noting some salt substitutes are very high in potassium chloride, like 50-60 millieq per teaspoon, which can be an option for some, but needs careful consideration.
Are there any downsides or risks with oral supplements?
Yes, there's an important safety alert here. Oral potassium supplements, especially older formulations, can sometimes irritate the stomach and intestines. In rare cases, they can even cause small bowel lesions, leading to obstruction or bleeding.
Ouch. So what should people watch for?
They need to be assessed for and definitely report any new abdominal pain, distension, nausea, vomiting, or signs of GI bleeding. It's not common, but it's serious.
Good to know. Any special considerations for older adults?
Yeah, older adults generally have less lean body mass, which means lower total body potassium stores. Plus, kidney function naturally declines a bit with age, meaning they might not excrete potassium as efficiently, so their requirements might be lower, and they could be more prone to developing high potassium if replacement is too aggressive. It requires careful dosing.
Okay. What about more severe cases, when diet or pills aren't enough?
For severe hypokalemia, say levels down around 2 MEQL, or if the person can't take anything orally, then intravenous or IV potassium replacement is necessary.
And you mentioned earlier this needs extreme caution.
Absolutely critical caution. Potassium is never given as an IV push, meaning injected quickly or given intramuscularly, ever.
Why not?
Replacing potassium too rapidly intravenously can cause fatal cardiac arrhythmias. It's also extremely irritating to veins and tissues. For potassium must be diluted appropriately, usually in IV fluids, and administered slowly using an infusion pump. There are very specific protocols for concentration and rate.
Okay, slow and controlled is the rule.
Definitely. We also need to make sure the patient has adequate kidney function and urine output before and during the infusion. If urine output drops too low, like less than 20 millimole per hour for 2 hours straight, the infusion usually needs to be stopped because the kidneys aren't clearing potassium properly.
What kind of monitoring is needed during IV therapy?
Close monitoring is essential. Regular checks of kidney function, BUN, and creatinine levels. Continuous ECG monitoring is often standard practice in severe cases to watch the heart rhythm. And frequent blood tests to check potassium levels, making sure we're correcting the low potassium but also not accidentally causing high potassium hyperkalemia.
It sounds like a real balancing act.
It is. And finally, thinking about nursing management and overall prevention strategies.
What are the key takeaways there?
Early detection is huge. Being vigilant for those early, maybe subtle signs, the fatigue, the muscle weakness, changes in bowel habits, those paresthesias, any hint of arrhythmia. Patient education is also vital, especially for individuals whose hypokalemia might be linked to, say, laxative or diuretic abuse, helping them understand the risks and find healthier strategies. And careful fluid balance monitoring intake and output is important, especially in hospitalized patients. Remembering that you lose about 40 millieq of potassium for every liter of urine output. Keeping an eye on ECGs and blood gas results for those characteristic changes or signs of alkalosis is also part of the picture.
This has been incredibly thorough. We've really unpacked hypokalemia from definition to management. It's clear how understanding this gives such crucial insight into how delicately our body systems are balanced. Knowing the causes, the sometimes subtle symptoms, and especially the very careful management needed, it's just vital information.
Absolutely. And if you sort of zoom out, connect this to the bigger picture. It really underscores how these seemingly small details of our internal chemistry, like potassium levels, are fundamentally essential for our overall health and well-being. It has such a massive ripple effect, far more than most people probably realize.
It truly does. This whole deep dive into potassium is a powerful reminder of just how interconnected everything is inside us. Small changes can have big impacts. And it leaves us with maybe a provocative thought for you, the listener, to consider. How many other crucial, but maybe often overlooked elements of our body's chemistry might be silently orchestrating our health right now, just waiting for us to pay a bit closer attention?